Critical Thinking and Coding Tips for Chapter 27. Okay, our first critical thinking question: what are the similarities between inpatient and outpatient coding? And our answer: some examples of similarities between inpatient and outpatient include the following. Code all significant secondary diagnoses on the basis of the guidelines for coding secondary diagnoses. Do not code conditions that are ruled out. This means that the diagnosis was determined to be no longer a possibility. A coder should not code from a laboratory finding or radiology report alone. Any ancillary finding must be correlated in the body of the medical record in order for it to be coded. Do not code signs or symptoms that are integral to the disease process. And our next question: what are CPT codes used for in addition to reimbursement? And the answer: CPT codes, like ICD-9-CM codes, are used for trending and planning outpatient and ambulatory services. This can be useful to hospitals to determine what areas of service are profitable and what areas are losing money for the facility. Benchmarking activities can compare and contrast services provided by similar non-acute care programs. This can help both the facility and the physician review what services are most efficient and generate the most revenue. Finally, the CPT codes can be used by physicians and quality assurance personnel to assess and improve patient care. In our last question: what is the difference between upcoding and unbundling? Upcoding and unbundling are both fraudulent activities and are a continuous focus of the OIG, which is the Office of the Inspector General. Upcoding refers to the practice of purposely assigning a code to receive additional or increased payment. An example would be coding a complication or comorbidity as a secondary diagnosis when there is no documentation in the record to support the code. Now, unbundling is the practice of using multiple codes when the services should be represented with a single code. For instance, if a patient has a lesion removed from the abdomen, in most cases the simple closure of a wound is coded. If a coder then uses a wound closure in addition to removal of the lesion, it would be considered unbundling. Okay, coding tips for this chapter. Now, we have completed the textbook as far as instructions on inpatient coding. Chapter 27 of the textbook will address outpatient coding. There are separate coding guidelines for each. In your ICD-9-CM codebook on pages 1 to 150 and 53 to 57, you will find a complete set of official coding guidelines for inpatient coding. Remember that an inpatient is a patient that is confined to a bed for more than 24 hours. On pages 51 to 52, you will find a complete set of official coding guidelines for outpatient coding. Remember, an outpatient is one that is seen for ancillary services such as blood work, x-rays, therapeutic services, etc., and ambulatory surgery or same-day surgery, emergency room visits, etc., and is confined to a bed up to 23 hours, 59 minutes, and 59 seconds. Now, facility charges versus professional fee charges. Both the hospital and the physician can charge for services performed at a given facility. In the inpatient setting, the hospital would be reimbursed on the basis of the MSDRG, and the physician can bill for specific services, such as consults, surgeries, etc., that he or she provided. Okay, continuing on with our coding tips. As far as the outpatient setting, the facility would be paid on the basis of the APC assigned to the visit, and the physician again could charge separately for his or her services rendered. This will often include adding a modifier on the same CPT procedure that the hospital billed for, and to show that the physician was the one who performed the service and should be reimbursed appropriately. Now, here are some differences between inpatient and outpatient coding guidelines. The term principal diagnosis is only for use in the inpatient setting. Outpatient coding uses the term first listed diagnosis as the first diagnosis. The term after study does not apply because outpatient visits are short and studies may not be complete before discharge. Signs and symptoms are often used as a first listed diagnosis because a definitive diagnosis will not be determined by the end of each outpatient visit. A possible, probably, likely, suspected, questionable, or ruled out condition should not be coded in the outpatient setting, but rather only in the inpatient setting. Now review the outpatient coding guidelines in Chapter 26. These follow the inpatient coding guidelines that are a part of the UHDDS, whose purpose is to define a set of rules and definitions for data collection within hospitals. Just like ICD-9-CM has Coding Clinic as the official source for ICD-9-CM coding advice, CPT has CPT Assistant that guides coders on CPT issues. It's published by the AMA on a monthly basis and addresses information on the correct application of CPT codes along with questions and answers from coders in the field. Now, reimbursement in the outpatient setting. APCs are used for Medicare patients who have services performed at a hospital. They divide outpatient services into fixed payment groups. Ambulatory surgery centers receive reimbursement at fixed prices determined by patient groups, similar to APCs but grouped differently. Fees for services provided to Medicare patients by physicians are determined on a fee schedule based on the Resource-Based Relative Value Scale, or the RBRVS. These were designed to provide a more symptomatic and equitable approach to physician compensation. Managed care organizations do not always follow the APC system when reimbursing. They usually have a fee schedule for both the facility and the physicians with a list of CPT codes and corresponding payment for each code.